Good afternoon and welcome everyone. Thank you for joining our webinar today to learn more about our partnership with OncoHealth. As a reminder, if you have any questions during the presentation, please feel free to put them in the Q&A chat at the top of your screen, which I will be monitoring. If we have time at the end, we will try and answer any questions, but if not, we will make sure your sales representative reaches out. I am your host, Kristen Wakelchuk, and I'm a marketing manager on the pharmacy team here at Excellus BlueCross BlueShield. And today I am joined by our speakers, Dr. Andrew Norden, who is the Chief Medical Officer at OncoHealth, and Morgan Prokopenko, who is a PharmD and clinical account consultant pharmacist on our Excellus team as well. Before we dive into the presentation, I want to take a moment to reiterate our mission to help people in our communities live healthier and more secure lives through access to high-quality, affordable healthcare. This mission is at the heart of our pharmacy strategy and everything that we do. By the end of this presentation today, you are going to know more about oncology trends in the market, as well as the power of our partnership with OncoHealth. So without further ado, I will now pass it off to Morgan.
Thank you, Kristen. So to start off, we're just going to go over some typical oncology trends that we're seeing. And again, thank you for taking the time out of your busy schedules to join our second webinar this year. So first, just looking at some trends to prepare for as we finish 2025 and going into 2026. So cancer is the second leading cause of death, and the incidence of cancer has steadily increased year over year, in part due to our aging population. We have better technology that makes detection of cancer easier. So 2025 is the second year in a row with over 2 million new cancer diagnoses that are anticipated. Typically, members that are diagnosed with cancer are 4 to 5 times more costly than those without. So keeping an eye on these trends is really important. When we talk about oncology drugs, we do have to consider both drugs on the medical and pharmacy benefit. So the market for these drugs is rapidly growing. We see development of targeted therapies. We now have those cellular and gene therapies that are treating cancer. So when we talk about cellular therapies, CAR T treatments, but also, going forward, looking at those newer gene therapies. Existing therapies that have been on the market are gaining expanded indications. A lot of the time we use the example of Keytruda was approved initially for one indication and now has can treat over 18 different cancers. So you'll not only have addition of new drugs coming to market, but expanding indications that are expanding the population that can get treated with these medications. Last year, we did see 16 novel oncology approvals that had an average cost of over $400,000. So these medications offer innovative treatments for our members, our population, but also come with a hefty price tag. Along the same lines, there is a very robust pipeline in the oncology space. A lot of the research and development is focused in this area. We'll touch on some of the pipeline on the next slide, but oncology is consistently one of those top trend drivers for our employer groups. So, whether we see it in the high cost claimants, we are experiencing double-digit trends in this space. So we'll continue to, again, monitor the pipeline, monitor those new drugs that are growing to put strategies forward to help maintain access to these drugs, but also keep those financial considerations. When we discuss pipeline, looking at it two different ways here, looking at the new drug approvals. So first half of 2025 has already seen 8 new drug approvals in the oncology space, with an additional 9 products that have potential for approval in the second half. Within the first 2 months, July and August, we've already seen 3 additional medications get approved for oncology drugs. But we also can look at it from the potential loss of exclusivity. So ways to offer, either generic medications or biosimilars to bring some relief to those expensive medications. So we do have several different highly utilized products that are projected to lose exclusivity over the next 5 years. When we talk about this year, looking at Tasigna. Next year, looking at common drugs that treat breast cancer like Perjeta. We have some Pomalyst, some oral medications, and then when we move all the way into 2027, 2028, those heavy hitters like Keytruda and Opdivo will have biosimilar competition. So on one end, there are a lot of new, more expensive therapies coming out, but again, some of those older medications will also come off patent to offer some savings there. When we jump into looking at the power of our partnership with OncoHealth, we first just wanted to reiterate our pharmacy value story. So the power of partnership and driving progress through partnership is one of the 4 main pillars of our pharmacy value. But we did want to touch on the other ones as well. So we do bring a more complete approach by having a range of cost containment solutions to help make medications more affordable, promote proper utilization, and improve the health of our community. Our model is built for your benefit. So, you get a partner with local and national expertise. And then the experience is easy for everybody. So we make sure that our members and our employers have a smooth experience with us by making compliance easier, integrating those solutions, and providing personalized care for each of those members. But what we're really here to focus on is driving the progress through partnerships. So to give our members the best care, we need to continue to keep improving, whether that's creating new services or programs or teaming up with organizations to bring the best of the best in the industry to our groups. So, we have talked about our partnerships with providers extensively, collaborations with drug manufacturers to come up with new programs. But again, here to really talk about how we've partnered with a specialized vendor. So especially in the oncology space, we recognize that we can't do this alone. And so we've brought Dr. Norden here today to talk about the strategic partnership that we entered with OncoHealth that's delivered significant savings in the oncology space. So with that, I will pass it over.
Thank you so much, Morgan. It's really nice to be here with you all today, and appreciate the time and interest. Let's go to the first slide and get started. So let me take a moment to just tell you a bit about OncoHealth, because many of you may not be familiar with our company. We are a purely oncology-focused company that has as its mission to deliver oncology-focused solutions intended to reduce the physical, mental, and financial toll of cancer for all the various stakeholders. We've been working across the country for more than a dozen years now, and have nearly 20 health plan partners in every geography, plans across all lines of business, and of a variety of different sizes. We support more than 12 million members. That's not to say that we support more than 12 million people with cancer, but we support a population of that size. And should those members be forced to deal with cancer, then we may offer our services. We are really proud of our provider collaboration with satisfaction rates that typically exceed 90%. We also have quite high consumer NPS scores, as you can see here. And our savings are typically measured in the hundreds of millions of dollars annually. The company was founded by a medical oncologist and has always been 100% focused on oncology for the reasons that Morgan described. Oncology getting increasingly complex over time, many new drugs coming to market, the cost of cancer care being as wildly expensive as it is. It's really made sense that we stick to our focus on oncology expertise. In order to deliver, we have a broad set of clinical experts across multiple oncology disciplines. We have medical and radiation oncologists, all board certified, and they are meaningfully supported by a group of oncology certified nurses and board certified oncology pharmacists. We also employ a team of oncology focused social workers who deliver mental health therapy and registered dietitians with oncology expertise. I tell people often that I'm incredibly proud of this team, and it's among the strongest oncology multidisciplinary teams that I've seen anywhere outside a large cancer center. So you heard a little bit about this from Morgan, but I will double down on a couple of points. There are many challenges in the oncology environment today, which is extremely dynamic and complex. One is the number of new drugs. We expect to see 100 or more new agents over the next 5 years. We've consistently seen 20, 30 plus new drugs. And if you count new indications of existing drugs, the numbers look more like 40, 50, 60 annually. If you know an oncologist and ask them what it's like practicing oncology these days, you will generally hear that oncologists are overwhelmed by the amount of new information, the numbers of new drugs, the complexity of those new drugs, the various monitoring requirements, biomarkers that are critically important and increasingly so in selecting the right therapy. Really, as we see the subspecialization of oncology and the molecular stratification of the disease, the burden on practicing physicians just has become really substantial. And in the face of all that, the median annual cost of a new drug in the United States at launch has exceeded $300,000. And I think we'll see in the next few years, it will probably exceed $500,000, which is extraordinarily expensive and really challenges the various payers, including employers, of course, health insurance companies, and also patients themselves who bear a meaningful portion of the cost burden that can cause bankruptcies and other challenges. So we have built over these dozen plus years a proven approach to help control costs and optimize the outcomes of cancer care for members of the health plans or employees of the employers that we serve. The sort of core operating mechanism for our utilization management services are described here. We have an electronic prior authorization portal that lives in the cloud and that providers can readily access from their offices to submit requests. We call that platform 1UM because one of the things about it that is unique is that all oncology requests, whether for a medical benefit drug or a pharmacy benefit drug or a radiation oncology treatment, as the case may be, all of those are submitted in the same portal. And another unique aspect of our service is that we don't operate like many utilization management vendors do on a single drug basis. Rather, we operate at the level of a treatment regimen. And that's because that is the way in which oncologists think about cancer therapy, and it is in fact the way that cancer therapies in the United States are studied and approved. Drugs tend to be given in combinations of 2, 3, 4, or more agents, and very often these days we see a mix of injectable and oral drugs across the medical and pharmacy benefit being used appropriately in one patient at a time. So that is the manner in which we clinically review requests for medical necessity at the level of the regimen. That allows us to improve the safety and efficacy of treatment that members or employees get, to reduce overuse of inappropriate therapies. It lets us look at the optimal supportive care agents that may be administered alongside those anti-cancer therapies. It allows us to think about what is the appropriate biomarker testing that must be done in order to ensure that we're making the right choices. And then when the review is complete, and the large majority of the time that happens within seconds or minutes, then the authorization gets sent on the back end, both to the health plan and the health plan for medical benefit drug authorization purposes, or to the PBM for the pharmacy benefit drug. That happens invisibly and behind the scenes. And I should say, just to be concrete, in general, absent a system like ours, a physician office typically has to submit the medical and pharmacy benefit drugs to different entities, maybe to the health plan or its vendor, and to the PBM separately. And our approach allows them to do it all together at once. So, how do we succeed in bending the cost curve? Well, in the process of the review that I described, which is automated where possible and leverages the expertise of the nurses, pharmacists, and physicians that I mentioned, where necessary, we're able to effectively reduce off-label or non-evidence supported use of drugs. I'm a proud oncologist myself and practiced for many years. But I admit that in my profession, oncologists like to go ahead of the curve and do things that maybe have some soft scientific rationale before we know that those things are likely to work in a human. And the cost and toxicity consequences of that can be really substantial. I talked about our medical and pharmacy benefit combination review. Something that we are really proud of, and that I credit our founding medical oncologist for infusing into the company, is that we try to find a way to say yes. We work closely with our physician partners out in the community, so that when we receive a request that we can't immediately approve, we work with them to come up with something that we can. We view our role in part as providing some degree of clinical decision support expertise to enable them to select a really great evidence-based, approvable choice. Naturally, we utilize our plan's preferred drug or step therapy strategies, and we work really closely with our plans to help them optimize those strategies, given that the evidence and guidelines base supporting these different choices is changing at such a rapid pace that plans really appreciate that level of support. We have a very engaged clinical team that not only interacts directly with requesting physicians, but also with clinical experts at our clients. Additionally, we support site of care programs that are designed to ensure that patients get treatment when safe and clinically appropriate at the most cost-effective possible site. Very often, A hospital-based infusion center provides the very same level of service as a physician office-based infusion center, typically at a meaningful fraction of the cost. And we're able to steer patients' treatments appropriately to those sites. Additionally, we support transitions to home sites for patients who can be safely and appropriately treated in the comfort of their homes. And then finally, we support vial optimization, which is to say that doses can be safely rounded in many circumstances by up to 10% with no impact on clinical outcomes, but with meaningful reductions in the amount of drug that gets wasted, and therefore, represents non-value added spend for the entire ecosystem, and we can help avoid that and do it largely in an automated way that is quite painless for the requesting physician. We describe our approach as white glove, and I think that if you talk to the physicians and their offices who engage with us, you'll hear that is true. A substantial portion, 90% or so, of initial requests can be approved very, very quickly within the system and don't require any human touch at all. So it's really a rather smooth and highly efficient process for the submitting oncologist's office to get the appropriate treatment that they want for their patient approved right away. We then engage in the collaborative discussions that I mentioned earlier, where treatment can't be immediately approved, and often come to an agreement with the requesting physician about withdrawing or modifying the request, so that there is, so that we can avoid the burden of a denial. And to do this, we leverage our clinical experts quite substantially. We communicate both on the phone and electronically with requesting physicians and help them make optimal decisions that we can approve. And then we maintain a low denial rate. And of course, sometimes this is unavoidable, but it's a key mechanism that the low denial rate is a key way that we sort of avoid abrasion to providers and frustration for patients. And also it means there are lower appeals volumes because there just aren't a lot of cases that have been denied in the first place. So I think that the way to think of this is that we believe as a core principle that the more often we can come to an agreeable decision with the requesting physician, the better it is for everyone. So I included one case just to give you an example of the kind of work that we do every day. And as I was prepping just a minute ago for this presentation, I realized we have an awful lot of clinical lingo that may be unfamiliar to some of you on the slide. So I'm going to try to turn this quickly into non-clinical lingo that you can easily follow. But this is a real case that came from the Excellus ecosystem of a middle-aged woman with metastatic colon cancer. And there are some descriptors of that cancer that aren't so relevant here. But the patient was treated with a common regimen for metastatic colon cancer that includes multiple drugs, four in total. The regimen is called FOLFOX with Avastin. And when you give that regimen, it carries with it an intermediate risk of causing a reduction in white blood cells called neutropenia that can result in infections that can be life-threatening. And as a result, it's appropriate when a patient is treated with FOLFOX and Avastin, it's appropriate to give some growth factor support And in this case, that was the case. The physician requested and had approved Udenyca, which is a white blood cell growth factor support agent that's given with each cycle and helps maintain the body's production of white blood cells and avoid this dangerous side effect that I mentioned. So in the circumstance that I'm describing here, though, we were getting a second request, a reauthorization request for FOLFOX and Avastin, and we observed in that request that that one of the drugs that comprises FOLFOX, called oxaliplatin, had been discontinued. The patient wasn't going to get it anymore. And the reason the patient wasn't going to get it anymore was that they had received quite a lot and they were experiencing some side effects from it. And there's good evidence that they probably didn't need to get that anymore, and they could be safely treated with FOLFOX and Avastin minus the usual oxaliplatin. And so they made that request to us, and that was totally appropriate and approvable and was approved in an automated way. What was challenging about this case, though, was that they had requested to continue the white blood cell growth factor, Udenyca, and our system flagged, and then our pharmacy team confirmed that when you take the oxaliplatin out of FOLFOX, then there's no longer an intermediate or elevated risk of having this problem with white blood cells. That issue goes away because the oxaliplatin is the cause of that issue. And so what we suspected was that the Udenyca was being re-requested just because it was part of the order set, not because the oncologist had a deep conviction that the patient needed that drug. Had we not gotten involved, it's almost certain that the Udenyca would have continued to be administered, which is not supported by guidelines in this setting. It has meaningful cost, about $3,000 or more every dose, and actually it has some safety concerns on its own if used in scenarios where it's not needed. So we called the physician. We had a very collegial conversation. The physician let us know that it was an error on his part, that he had requested reauthorization of Udenyca, ordered reauthorization of Udenyca, and was agreeable to the idea of removing that. And so going forward, of course, we were saving $3,000 every time this patient got chemo every 2 or 3 weeks. And avoiding the downsides of inappropriate therapy. Now, every example I could give you isn't quite so smooth and easy as this one. I don't want to give that impression. But at the end of the day, I think the key observation or the key insight here is that we're keeping an eye on these patients. We're providing an extra set. We're providing some extra oversight, some checks and balances. So that if a physician wants to do something that, if a physician does something that perhaps they didn't intend to do, or they want to do something that's not quite yet supported by strong evidence or guidelines, we're going to work with them to figure out how to move forward in the best, safest, and cost-effective way for the patient without compromising benefit of therapy. And that's what happened here. So at the end of the day, we are a proven oncology management program partner. We've had a terrific partnership with Excellus that we're proud of. We lean on our expertise, which is deep in clinical oncology across multiple modalities. We work hard to execute smoothly so as to make the process of interacting with us as easy as possible for physicians and their patients. And we measure and report on our impact, which we're proud has been strong. So with that, I will pause. I see Kristen has returned to the screen. I will hand it back to her, and perhaps she will take some questions.
Yes, we do have some questions that have come in. Thank you so much, Morgan and Dr. Norden. I actually have a couple questions that I will be directing back to you, Dr. Norden. The first,
Okay.
Could you speak to how you collaborate with oncologists in the market?
Yes, for sure. So I'd highlight two things. Um, the first is when we enter a new market, like we did in New York, we meet with the key uh, provider network partners that are seeing the members and taking, providing oncology care, so that we can establish effective working relationships. And the idea is we don't want to just be like we don't want to come off as sort of a behemoth that is lives behind the computer screen, or behind the telephone, but we are humans who have oncology expertise, and who are eager to help optimize care of patients with cancer in the market, and we establish really good collegial relationships in that way, and make it clear that our interest is in partnership rather than denial production. And then I think secondly, I hit on some of this during the conversation, but the richest conversations really happen at the level of the physician to physician, or in many cases, OncoHealth pharmacist to practice pharmacist, or OncoHealth nurse to practice nurse, staff member. So when we have a case that is not immediately approvable, we find that a large portion of those can be resolved just by direct communication between the clinical experts involved on both sides. And I really believe that is our special sauce, our desire to figure out a yes. We also, I would say, strongly leverage the fact that we have this big clinical bench. And so it's very typical, I would say, that a physician will say to one of us on the phone, well, what should I do? Or how should I think about it? And of course, our job is not to treat the patient. We're not practicing medicine, but often what we can do is share our assessment of the landscape for a particular treatment scenario. So, like recently, we had a really challenging multiple myeloma case. You may be aware that the numbers and types of drugs for myeloma have exploded in recent years. And we were able to provide some sort of a scholarly synopsis of some of the key studies in a challenging myeloma clinical scenario that the physician found really helpful. Now, we also do the same for our health plan clients to help them develop policies about optimizing therapy. But we leverage that information in our one-to-one interactions with clinicians, and in that way show our value and help ensure patients get the right therapy.
Thank you. And then you mentioned that OncoHealth performs regimen-based review. Could you just speak a little more about what that means and why it's important?
Yeah, of course. So this is a unique aspect of oncology care. In general, utilization management operates at the level of the individual drug. A physician wants a drug for the patient's diabetes or high cholesterol, and they request it. And of course, it's important for the physician to know what other drugs the patient may be on from the standpoint of drug interaction risk. But they don't really have to think about the entire cocktail from the standpoint of treatment efficacy. In oncology, it's actually relatively uncommon. I'd say maybe 20 or 30% of the time does a cancer patient get treated with a single drug. So most of the time, one is being treated with a cocktail of drugs. The case I reviewed a minute ago, FOLFOX Avastin, is a good example. 4 drugs in there, plus the supportive care drug. And that's really typical. If you look at oncology clinical trials that lead to FDA approval, what you see is that the drugs are studied in these combinations, and that's how we prove their efficacy. So I think that the reason regimen-based review is important is that if you only consider one drug at a time, you may miss that the drug is being used in a way that's either unsafe or not effective. And so this causes challenges because the claims systems need to be able to pay for these drugs, of course, based on the benefit type. Is this a medical benefit drug, or is this a pharmacy benefit drug? But from the standpoint of knowing what's clinically appropriate, what biomarkers are needed, and whether there are alternatives that might be equally effective and safe but lower cost, you really have to consider the treatment in its entirety. And so that is how we've designed our operation, to focus on the whole sort of holistic review, including all the anti-cancer therapies, all the relevant supportive care therapies in a bundle.
And then we have one more question that has come in for you. Is the
Okay.
review process communicated to the patient? For example, are they notified if a drug request is denied, or is the communication solely with the provider?
So we leave that up to our health plan partners, and it varies by health plan, geography, and line of business. I would say in general, for most circumstances, we do notify patients of the decision, and we can do that in writing or by phone, or both, depending on our client preferences. But I would say from a clinical perspective, increasingly, I think that doing that is a really good thing. Patients deserve to be part of the process and understand what's going on and why. And I will say that a meaningful portion of, although I showed you our denial rate is low, a meaningful portion of denials relate to just a lack of information flow. There's a key piece of data that OncoHealth needs. Without it, we cannot issue an approval. And so sometimes the patient can be very helpful in encouraging their oncologist's office to share that information in a timely way, so that we can get to a yes more quickly.
Yeah, and I'll piggyback on that. We do, if there is a denial, both the provider and the member are notified.
Thank you both. And with that, we have 2 minutes left, so we are just at time to wrap up. I am going to send out a quick poll just to get a gauge on how you like today's webinar content. I also want to extend a heartfelt thank you to Dr. Norden and Morgan for joining us today. We truly appreciate the time and expertise you have shared with us, and it has been a pleasure having you here. And to everyone who attended, thank you for the engagement, the questions. We'll be sharing the recording shortly, and until next time, take care. Thank you, everyone.
Thank you.
Thanks so much.